Hey everyone, welcome to this session on non-epileptic episodes. Yeah, so this is something that's important to me because I think we all know that it's quite common for GRIN patients to have epilepsy and seizures. And so for all of my son Bryson's life, we have sort of been wondering if he's had seizures or not. He has these episodes, and a first neurologist, they have not been picked up on an EEG. First neurologist ruled out seizures. Another neurologist saw one of these episodes when Bryson was in his office and said it certainly looked ictal. So Bryson's been on treatments for epilepsy, and we're still not really sure, but these episodes can be quite long and sometimes violent. Bryson's hurting himself and those around him. And if you give me a minute, it's going to take me a second because I just came straight from the last session. So I need to get something set up here. Yeah. Okay, great. So here is our panelists today. I'm going to move on so we make sure we have time to get through everything. But earlier this year, I did a podcast with the Canadian Broadcasting Corporation about Bryson and GRIN disorder and our search for a cure. And one of the things that I talk about in there is about these episodes. So I'm going to play a short clip from episode 2 of the podcast where Bryson's brother and I are talking about these. Okay, sorry, it looks like people are saying that they can't hear it. So apologies for that. So basically, this is my son Connor and I describing this, and I'll just talk really quickly about what we often see, which is that we often know one's coming because Bryson will stick out his tongue. He'll sometimes try to kind of cover his head like this. Sometimes there's laughing involved. Sometimes there's a lot of grunting. His whole body gets tense. His feet kind of twist. And then he'll start sort of writhing and can become quite violent, biting himself, scratching himself. If people are around him, he'll sometimes do that to others as well. His body temperature rises, his pupils get larger. And the interesting thing is that in addition to these both starting very suddenly, they also end abruptly. So all of a sudden they'll just stop and Bryson makes a clicking sound with his mouth, and afterwards he gets very tired and also thirsty, but often just falls asleep right after. And so I will turn things over to Dr. Benke or Garcia. Thanks so much to the two of you for joining us. Had you guys I can't remember, had you put anything together to sort of start with?
Yes. So if you stop sharing your screen, I'll pull up my screen.
There we go.
Here we go. There, you should be able to see my screen now. So thanks very much, Keith, for asking Dr. Garcia Cazorla and myself to chat about this today. This is a really important topic to patients and families. And so we want to just talk about what was that and how we approach spell assessment. And so I listened to the podcast that you provided about Bryson spells, and Amela sent me a video of Aaron's spells. And so I won't show that video because we weren't sure if we wanted to show it, but I'll describe it for you as we get there. Quickly here, my disclosure. So what I think that we're going to talk about is, as pediatric neurologists, Dr. Garcia and Cazorla and I will talk about the key questions and what we think about as pediatric neurologists in trying to figure out spells. What are some of those diagnostic tests in trying to figure out spells? And how do you determine a possible therapy or approach to the spells? So Aaron's spells, this is the description that I gleaned from the video. They happen at night. They can last 5 minutes to an hour. They escalate. They can involve hysterical crying or laughing. His arms will be above his head. He'll wave them in front of his eyes or biting his hands. It looks like he's trying to defend himself. His body may be stiff. It'll be rolling from side to side on the floor of the bed where he's at. His legs are kicking or still or rolling side to side with his body. His eyes will be closed or half open, and his head is going side to side with his body. And clearly, from watching the video and hearing what Keith is describing, these can clearly be very upsetting to families to see these sorts of events. And clearly to Bryson and Arian, they're upset during these spells. So they're concerning. So there's a lot of questions, and this screen here is a bit busy, but there's a lot of questions that we like to ask when you're trying to understand what a spell was. And always, it's very helpful if you can see a video. And we appreciate that you're trying to comfort your child, and somehow with your third arm, you're trying to hold your cell phone to get a video at once. And it's very difficult. But still, that's very helpful to us if we can see an event from start to finish. We want to know what happens from start to finish, what the eyes are doing, what the arms and legs are doing, what is the nature of the movements? Are they very repetitive, or do they look chaotic? Is there a color change? Do they get sweaty? Do they get cold? Do they hold their breath? Do they hyperventilate? What sort of noises are made during the spell? If you touch the child, how does that interrupt or change the spell? We want to know, how often are these happening? When do they start? How long do they last? Do you think there's anything that triggers a spell? Do you think that there's anything you do to make it stop? What does your child do after the spell? Do they go back to normal? Do they go to sleep? What's different? We also want to know, what have you guys tried? Have you tried anything that makes it better or worse? And also, what have your clinicians done to try to figure out what's going on? So the spells for us is, what are the possibilities? That this tells us, well, what are the treatments? So the description plus some diagnostics will hopefully give you an answer to suggest a therapy. And this always is a clinical decision. It's not a binary, oh, this is exactly what it is. It's always kind of an analog thing. Well, I think it's this, or, oh, no, I'm really sure it's that, or no, it's not this. So it could be a seizure. It could be part of a movement disorder. It could be part of a sleep disorder. It could be part of autonomic instability. There could even be a change in your anatomy. In other words, if there's something new going on in your brain, it could be a behavioral spell as well. But also, there's a lot of times where like I said, it's a clinical decision. We're going to say, I don't know what this is. I know what it's not. I'm leaning towards these are possibilities. And these can then suggest that, well, let's do a trial of therapy. Say you think that there's seizures. It's not unreasonable to do a trial of therapy with an anticonvulsant to see if it makes them better. If it's autonomic, maybe there's a trial of something that you could think of that might make them better in that regard as well. The diagnostic tests that might be considered, yes, I like the cell phone video because it captures you in your natural state, but we talked about how it's hard to do. And you don't get much physiology from that. The video EEG gives you the ideal recording conditions, but like Keith was saying, you have to be lucky enough for your child to have one, if lucky is the right word, when you're hooked up to the EEG. Same thing for a sleep study. Same thing for an extended heart test like a Holter or an electrocardiogram. Imaging is only useful, in other words, an MRI or CT scan, if you really think that there's been a change in the anatomy. But it's not really useful or needed if it's already been done as part of the initial diagnosis. So my conclusions here before we get to the Q&A is the therapy, of course, it depends on what caused the spell. It depends on the nature and physiology. But also, you need to understand the impact of the spells. If these look very impactful, I think that we need to think about doing trials of medications. But when that comes up, there's also, you need to consider what's the side effect profile of the medicine that you're prescribing. And then I think also, whether you know what it is or not, you want to try to ensure the safety of your patient and child during the spell. So that's the end of my slides. So I'm going to switch over to Dr. Cazorla Garcia, and I'll mute myself so as not to have any feedback, but I'll advance the slides for you.
Okay, thank you very much. So I'm going to introduce just a couple of examples that are really very short and quite easy, because this is a very common problem. We are really often faced to this challenge of the differential diagnostic of making the difference in the origin of these spells. So this is like a very common clinical problem in our daily practice. So let's see the first example, that it's about a patient with abnormal ocular movements. And next slide, please. Okay, so this is a patient with the video is published in a journal in neurology. It's an open access video. That's why I bring it here. So in an 11-year-old child with these abnormal eye movements, you can see this sustained, conjugated, and upward deviation of the eyes. These episodes can last from seconds to hours, and sometimes these are really subtle, but in other occasions are really painful and can associate other abnormal movements like neck flexion or jaw opening, sweating. Very often the child feels uncomfortable and cries when she has this kind of abnormal movements. There are no other associated abnormal movements of arms and legs, and these spells not change when parents touch the child. So according to all the information that Dr. Benke has mentioned before in the slides before, do you want to know something else about these spells? I mean, do you need some additional information to try to understand a little bit what is happening, to make the difference between a seizure or another kind of problem? Do you want to know something else about these abnormal movements, or what is happening, what other signs or what other problems are associated to this? This is something a little bit difficult maybe for parents, but just in case you have a curiosity to know.
Can she talk during these spells?
No, but well, if the spells are I mean, if they are really very short, brief, and between the spells, she could talk. But at the moment, well, maybe if we insist, but in general, no.
It's interesting that she rubs her eyes during the spells.
Mm-hmm. It seems to be, I mean, she could understand everything that is happening around. So the level of consciousness does not decrease. She is, I mean,
is she taking any medications that seem to have triggered these spells?
No, not at that time. Later on, when the diagnosis is discovered, but not at that time. Okay, so these abnormal, repetitive ocular movements sometimes are associated with epilepsy. So that's why in the next slide, please. So this child had an EEG, but the EEG was normal at the moment of the spells. It is quite important if we think that these abnormal movements or repetitive spells can have an epileptic origin. It is important to have an EEG registration at the moment of these abnormal movements. So it was absolutely normal. And then so the possible diagnosis here are oculogeric tics, although it is not really in the context of the child with other symptoms associated, it was not a possibility. There is a syndrome or a clinical syndrome, paroxysmal tonic-up gaze, that can be related to different problems. But finally, what this child had is oculogeric crisis, which are this is a kind of abnormal movement. These are dystonic movements, in fact, and in most of the cases, it is related to an abnormal dopaminergic transmission. So if we go to the next slide, this child, in fact, had a problem in the synthesis of dopamine, both dopamine and serotonin, because of a rare disease that is called amino acid decarboxylase. So this child don't have a GRIN disorder, but these oculogeric crises have been described in GRIN 1 patients. And well, as I've seen some GRIN 1 patients with these abnormal movements, but at least in my experience, and maybe we had to study that in detail, but in the difference between the oculogeric crisis secondary to dopaminergic deficiency, that in this case, and the GRIN 1, is that these oculogeric crises are really very fast, are faster, and they can be in different directions in a short period of time. Whereas these secondary to dopaminergic deficiencies normally are more repetitive. They look alike all the time and last longer. But well, this is just a personal observation that it has no value unless we have a longer, a study that is done very, very well structured and with more patients. So this was one situation. So the differential diagnosis of these abnormal ocular movements, and the second case. This second case, well, it is another patient who started to have 3 years of age, what we call myoclonus, and repetitive segmental myoclonus is a contraction of a group of muscles, a very brief, very, very quick contraction, and that can be localized in different places. So this child has contractions at the level of all the arms and the legs, very random. Then 3 years later, he started to have another kind of abnormal movements. This is a video that is also an open access video, but doesn't correspond to this child, but it's just to illustrate that this is a chorea. So this is a kind of abnormal movement, repetitive, non-rhythmic movements, but also random, very brief, like a little bit like a dance, generalized in most of the cases. And a little bit later, when he was 8 years, so he had another kind of abnormal movement, because at that time they were different from the first ones, and they were in fact flexor spasms, so a flexion of the trunk of the body, and associated also to a deviation of the head. And so these are different kind of movements, different spells, let's see, like that. And well, in this scenario, we need to know also some kind of information from a clinical point of view, descriptive information from parents, just to try to understand why the child is having these abnormal movements and repetitive spells. So is there anything that you want to know in this child to have more information and to try to understand what is happening?
So the new spells, does the child sleep after the new types of spells?
During the night, you mean? Well, during sleep?
The flexor spasms that he's having now.
The flexor spasms that is having now appear at any time. I mean, not only in a particular moment of the day or night. He has that during the day and not during the night.
Does he sleep or cry after them?
Yes, he sleeps after them. Yeah.
Is he conscious during the?
No.
Okay.
So these are elements that go in favor of a possible epilepsy, not the first type of abnormal movements, but in the third one, well, there are some elements that point to a possible epilepsy. So the child in the next slide had an EEG that we can see during at night while sleeping. We can already see some discharges, some spikes. So the EEG shows the electrical activity of the brain, and here we can see this discharge. At that time, while he was sleeping, he didn't have any kind of abnormal movement, but we can see already some kind of hyperexcitability, some kind of possible epileptic activity. And later on, he had a generalized tonic-clonic seizures. So here we can see for sure all the abnormal activity that is very important in all areas of the brain. So generalized seizure. So, well, this was the second case, just to illustrate that in some cases it is not rare to find a combination of both abnormal movements and seizures. And so, and we, from a clinical point of view, we have to have all this information regarding how is this abnormal movement, how the spells are, when they happen, what is happening to the child after. And then also it is really important to have at least an EEG or several EEGs. Also sometimes at night, a long EEG during all night long. And well, it depends on every patient and every circumstance. So well, this is something quite common in our clinical practice.
We only have a couple minutes more for this session before the Q&A starts, but I believe that both Dr. Benke and Dr. Garcia will be on that session. So maybe some of these questions could be asked again there. I just want to make sure it doesn't look like Amela is going to be able to share her story with us. So let me just see if did you have a lot more to present, Dr. Garcia, or should I see if we have time for a question or two? Okay. Thank you, though. That was really great. So there's a question, do we know how common it is among GRIN for these non-epileptic events?
Well, we know that they can have, abnormal movements, hyperkinetic movements, different type of hyperkinetic movements, such as what we call stereotypes that are repetitive, without a purpose movements. They can also have more like dyskinetic, like a torsion of the arms, of the legs, and they can also have these oculogenic crises that I mentioned before. In GRIN 1 patients, we see that quite often. And then they can also have seizures. I mean, they can have abnormal spells that are related to a normal EEG activity, and this can be also epilepsy. So they have this combination of different things, and it is up to the clinician, the physician, to try to differentiate, also to treat properly those kind of abnormal spells. Dr. Benke.
So we don't know for sure yet, Keith, but they're not uncommon. So Johannes has some good data through his registry, because he's been collecting these, and they've been calling them autonomic storms. And so we've modified our questionnaire to make sure that we're capturing both the oculogenic crises as well as the storms, just to make sure that we have it all in there so we can answer that question. But they're not uncommon.
Well, this was really great. I'm sorry that we weren't able to hear from Amela, but it was great to hear from both of you, Dr. Benke and you, Dr. Garcia. So thank you so much. Just want to let everybody know that the Q&A, the Ask Me Anything, is starting in 1 minute. So this session is back on the main stage. So if you don't get connected there directly, just make sure that you're logging into the main stage section on the side of your screen instead of the sessions section. Thanks, everyone, and we'll see you there.
Okay.